Prof. Kato,
Anila, yeah, Sharon, you can.
Kato, would you like to say something before we start?
Oh, it's fine. I mean, it's a very great honor for receive the president, the 𝑁𝑎𝑗𝑖𝑎, good friend for many years.
Thank you so much. Thank
many
you
years.
so much.
And also the speaker, the 𝑘𝑢𝑠𝑢𝑚𝑖, and also she's from Japan, and also
Mohira.
Sorry. Mohira, she used to be with us. So very promising, the lady neurosurgeon from Uzbekistan. Anyway, thank you very much for having such a nice webinar today. So please start.
Okay, so good one. We'll start with today. Our chair will be Prof. Anila Daba. So Anila, we'll let you chair the whole session. Just me and Abida and me will just be the moderators. But we'll also have two discussants today, Prof. Alexander and Prof. Binsu, and followed by two esteemed speakers, Prof. Kusimi and Dr. Mohira. And of course, today we are very honored to have our very own first woman president of the World Federation of Neurological Surgeons, Professor 𝑁𝑎𝑗𝑖𝑎. It is a great honor to have us with us today, especially this being March, Women's Month, International Women's Day, and we hope that keeping with the theme, we invest in women and continue to progress. So, Prof. 𝑁𝑎𝑗𝑖𝑎, you want to start?
Okay, thank you so much, Sharon. Dear colleague, dear friends, thank you first. And for me, it's an honor also to serve the World Federation of Neurosurgical Society and to be with you today. Even if we are in 17 March, we still, celebrating the Women's Day. So I would like also to first to congratulate my dear friend Yoko and all the speakers here today, and also my friend, all my friends, but especially my friend Bingshu. I would like to thank her for many things. First, for for their job, their huge and tremendous job for a young neurosurgeon. She still this job for many years, and she helped a lot of the thousand of young neurosurgeon. And I remember we had at least I think 3 times in Morocco, Yoko, and Bingshu also. The last time, we appreciate your participation with the Japanese team. First of all, today we celebrate, as I told you, this month, not only day, but I want to shine a spotlight on the remarkable women who have choose a path less traveled. The women who have become neurosurgeon in a field where precision and empathy intertwine. There is trailblazer exemplify strength, intelligence, and compassion. As we honor to achievement of women neurosurgeons around the world, let us acknowledge not only their exceptional surgical skills, but also their dedication to pushing boundaries, breaking barriers, and inspiring the next generation of aspiring the neurosurgeons. Their impact extends beyond the operations operating room, leaving an indelible mark on the landscape of medicine and redefining what is possible. May we continue to support and uplift these extraordinary women in neurosurgery, recognizing that their contribution not only advanced medical sciences, but also pave the way for future where every individual, regardless of gender, can pursue their passion without limitations. Happy International Women's not only Day but month to the women who challenge the statu quo and redefine excellence in neurosurgery. Your courage, of course, my dear Yoko, and brilliance light the path for a more inclusive and promising future. Thank you again for your invitation. And in the same, because we are in the month of the women, my talk will be more social to happen. Okay. Will be more social than scientific, because I know that when I see all the participants, I think it's my duty to speak about little WFNS for the first time, as it's my second or my third presentation after to be the president of WFNS. So my presentation, it's WFNS beyond 2023 or 24. This is, of course, for who knows Morocco. And this is Rabat, of course. Rabat is the capital of Morocco, as you know. And I hope that you will come, welcome you here in Rabat as soon as possible for next, of course, meeting in a few months. So in Chinese, crisis is written in 2 words, as you see here. The first one mean dangers, the second means opportunity. I believe that the danger is behind us and that we can continue, of course, our work. Today, we have the opportunity, of course, because the danger is behind us, and the opportunity to be exemplary, the opportunity to strengthen our neurosurgical community and its ability to weather hardships. Dear colleagues from all over the world, let's show solidarity, patience, and resilience. I believe also that WFNS need to improve its governance with putting in function a participatory management in an environment of cohesion and unity. This is very, very important, and we need to applicate in the future. So we need this environment to work for our mission, and as an administration, our mission is to have a stronger federation that could bridge the gap in neurosurgical care, and to have an inner collaborations of all members for better educations and practice in neurosurgery. Okay. For this, we fixed 3 main goals: create more opportunities for training and fellowships, improve the financial resource of the WFNS, and develop neurosurgical care in countries in need. To achieve our first goal, we will follow, consolidate, and develop WFNS programs. As an administration, we need to be creative. I belong to LMIC. Many of you belong and work in LMIC, and we understand even more what we need. We need to be creative and proactive. We will create new sponsored opportunities for basic training in neurosurgery and fellowships for neurosurgeons from LMIC by increasing the fundraising possibility through new international partnership. So it is obvious that I am not an English native speaking. Be sure I do not pretend. I am not a woman of words. I believe in work, in action. Action speaks louder than words. And fundraising is daily work for WFNS president and WFNS administrations. During my 2 years as president-elect, I was seeking for funds to reach these goals, and I am happy today to announce you that I had a preliminary agreement with the Moroccan government to sponsor with the $100,000 training for first African neurosurgeon. This agreement will be signed and start soon in Morocco. It will be the goal. It's to double the awards for scholarship for the young neurosurgeon training in Africa, from Africa in Africa. So we'll allow to double the capacity of training of WFNS Rabat Reference Center, because I told you about that because it's the first one, not because I am Moroccan. So to train qualified neurosurgeon in less time and reduce the lack of neurosurgeons in many LMIC countries, that is it's just for to continue, of course, the work of my predecessor as president of the WFNS. This is not enough. I know, because there is not only Africa, there is Latin America, some countries in Asia. Our synergy in action is mandatory. We will share the experience with other reference centers and governmental institutions, as we did in Morocco, and support different centers' program for training around the world, and establish a sustainability program of neurosurgical training. Is very important. The sustainability is the goal of our work in the WFNS. A federation with the resource can invest more in developing neurosurgery. And this is why we need a diversity in income of the WFNS. We need to mobilize existing resources by increasing members and donations, and rationalize our experiences. We need to think outside the box. And create special program allowing to firms, governments, and international institutions to join this goal movement for neurosurgical care for all. We have to develop neurosurgical care in countries in need. This is very important. I mentioned many times before, but I continue to mention it all the time, because one of this is in my opinion is the first goal that I had to achieve. And the 5 million human beings per year waiting for us to help. Are we ready to help? I hope, I think no, but we hope that in the future we can be we could do it. And are we ready to do our mission? This is, I think it's yes, we will do it. And I hope and I wish that we can, of course, attain our objectives. It is good to teach neurosurgery, but it is better to establish or help to establish new departments of neurosurgery. And by providing equipment and also transfer of the experience to local teams. This is very important, because when we have in some humanitarian experience, you did just for 1 week, and when we come back from the country who needs of the neurosurgeon and neurosurgery, who can take care of these patients? So this is why I am talking about to transfer not only to transfer the knowledge, but to start to build a department of neurosurgery. This is very important point. So we are all volunteers, and many of us are trying their best to help, but it is a matter of synergy of our action. We need to be in synergy of all our action. If I did my action in this place, the other in other place, but there is no synergy between us, and this is very important. I hope in the future we can achieve it. So this goal consensus will have as goal to strengthen educational activities such as international courses, support new technologies for sharing knowledge, learning on simulation, and hands-on workshop. We see that is a good thing during last crisis with COVID-19. Increasing the number of local training programs and reference centers, as I already said. So, and how we are going to do that? We will have to support of the WFNS Foundation. Please be more, give money without counting. It's especially as donation. The Education and Training Committee and many other ad hoc committees will develop a full package program with clear goals and tools to be duplicated and adapted to different centers. Many of us is specialized neurosurgeons, member of very active, dedicated societies. We need to collaborate to all societies, non-members of our federation, but that are ready to help and develop neurosurgical care where it is needed. There is disparities in educations and training between high-income country and low and middle-income countries. Establishing exchange programs between these two different parts of the world will help to understand what is really happening in LMIC by high-income country, and transfer the experience and the knowledge by high-income countries to LMIC. So this is only way that we turn this dream to reality, to have one word with one neurosurgery. And I believe in a global neurosurgical beyond the numbers. I hope that there is some of you attend the last international symposium in Peshawar about global neurosurgery. Unfortunately, I couldn't do it because I have some problem issues, and it was very, because I follow through the Zoom time by time, because they have some problems with the Zoom, and it's very, very interesting, and we need to continue in this way. I believe also in global neurosurgery for all continents, and for all, of course, for all nations. For a best neurosurgical care for all human beings. This is very important. We don't not because we are from LMIC, we need our proper, neurosurgery. No, we need to have the best and the same neurosurgery for all the human beings in around the world. So I believe that together we will succeed. So are you ready to join me, to join us, and to change the things that I mentioned? I hope that you are, I'm sure, for at least many of you, or maybe all of you, to be ready to change this neurosurgical and to improve neurosurgical around the world. And I remember last years, I think one of neurosurgeons, a female, sent this by WhatsApp, and it's the 8th March is the Happy Women's. As I told you, to be you need to be strong and to be bold, but not just this day, but for every day is very important. We need that for every day, and you can succeed. Thank you so much for your attention.
Thank you so much, Dr. 𝑁𝑎𝑗𝑖𝑎, for your insightful ideas, your thoughts, and all the great work that you had been doing as the president-elect of WFNS. And we are looking forward for all the wonderful work that's going to be coming in the next 2 years. I want to also congratulate you as the first female WFNS president, and I'm very, very proud of you.
Thank you so much. I know that Anila, there is some change recently in the WFNS, but really it's we will change it. Don't worry, because we are changing and coming back. You are the chair for me. You are the chair of women in neurosurgery, and we will in a few days we will change the things, because there is some problems, as I told you, in the WFNS in the beginning, and we will meet in Prague, and we will in person, so it's more easy, of course, to have a solution for all the problems.
Thank you so much, 𝑁𝑎𝑗𝑖𝑎. And I just want to open the discussion. If anybody has any questions for 𝑁𝑎𝑗𝑖𝑎, to ask any question.
Yes, Dr. Fawad is raise a hand. Anila?
Yes? Yeah.
Dr. Fawad. Yeah.
Go ahead, please.
Hello.
Hello.
Assalamu alaikum. Assalamu alaikum wa rahmatullahi.
Assalamu alaikum.
Konnichiwa. Thank you, Professor 𝑁𝑎𝑗𝑖𝑎 𝐸𝑙 𝐴𝑏𝑏𝑎𝑑𝑖, Professor Yakub and distinguished colleague and professors. Assalamu alaikum. Thank you very much. I'm very impressed by your speech. Thank you. And I also follow your speech on global neurosurgery in Peshawar. It was great, and I saw your mission and your goals. It was very ideal for us. You know, I'm from Afghanistan, and we have one problem in Afghanistan, because Afghanistan is low income country and very poor country, and also we are in sanction now in Afghanistan, and our border are closed. We have in primary neurosurgery. And we need also for your support. We would like to say thanks for WFNS Foundation and also from ACNS that always, especially Professor Kato, support Afghanistan neurosurgery, but we like more supports, and the WFNS Foundation also support Afghanistan neurosurgery, but we like more. We like also, as you mentioned, equipment and also training, and if it's possible that we send our colleagues from Afghanistan, especially young neurosurgeon, to Rabat or to other neurosurgery training centers. And we also, you believe we still use the hand drill for do craniotomy in Afghanistan. And we need more experience and training, and also if it's possible to establish a neuroscience institute in Afghanistan for our needed people, you know. And unfortunately, I haven't got the chance of visit Pakistan in this global neurosurgery conference. And I had presentation down there about neurosurgery in Afghanistan. And I like to draw your support, and also our all colleagues from Asian countries, also World Federation of Neurosurgical Societies, for supporting Afghanistan. Thank you very much. Shukran. Konnichiwa.
Okay, so thank you, shukran jazilan. What I can to promise you that I will put that in the next. We will have on 1 or 2 weeks. I programmed the first meeting with the foundations, because you are a little bit taking a time, because after the end of the meeting in Cape Town, unfortunately we have many Christmas and also the New Year, etc. So all this for this reason we start really working in January. But about what you are requesting, I assure you that I will put that in on the agenda for the next. But I would be happy if I can have one name, and who can all the neurosurgeon in Afghanistan belong to the same association, or like think this. I think there is no society. There is Society of Afghanistan now or not yet?
Yes, we have Afghanistan Neurosurgical Society. This is the honorary member of WFNS.
Okay. Affiliate, you want to say, or honorary? Honorary is different.
That's honorary, affiliated member, yes. Affiliate,
okay. So if affiliate, we have normally the 2 delegates, and if there is a president, I can also inviting him in one of the meeting with the foundation, and so one we can do for you, of course, concretely in the on site. Okay.
Okay, thank you. I'm now the president of Afghanistan Neurosurgical Society.
Okay, send it to me. You have my my email.
Yes.
Send it to me, and I will I will put that in the agenda to discussing with the
Okay.
next chair of the foundation.
Thank you very much. Shukran.
It's my pleasure.
Arigato.
My duty.
Thank you. Thank you so much, Dr. Fawad. Dr. Najia, I just have sort of a recommendation, and can you hear me?
Yes, yes.
Yes, sorry. It's that, in the global neurosurgery meeting in Peshawar, of course, we missed you terribly. But this one idea that was raised that, it's always the LMIC fellowship neurosurgeons that are going to high income countries to learn. But there is also a lot of learning that can be done in LMIC. So there also should be a reverse trend, which means that trainees and residents from higher income countries should also come to lower income countries to see all the different pathologies, because we have a very high volume of pathologies here. So it would be nice that if the LMIC people can go to higher income and the higher income can come to LMIC, so that there would be a mutual learning going on in both the directions.
Yeah, I completely agree with you, Anila, because we know that there is some fellowship till now. There is fellowship from LMIC to the high income country, but the problem, it's more political, and with the visa, it's not easy. But if you have the fellowship signed by by the department, and that's it's very good and very nice, because it simplifies for you the things. This is why in the AC, the most officers who are with me in the AC are from a different continent. From Europe, from the maximum are from Europe, and also USA. And we discussed about this point, and there is many departments till now. I'm asking for young neurosurgeon to have a fellow for 2-3 months, or one. But the problem, it's not you have to to looking for it, and this is the problem. We need to I told him the last AC meeting that we had, that please, we need to know who are able to to have fellowship from LMIC, and to give it to the WFNS and put it in the website. It's more fair for everybody, because now if you want to go to have a fellowship, you have to do it by yourself, and sometimes it's not easy to have fellowship. And then you are right also, because some some neurosurgeons for high income country need to be time by time, not to stay only 1 week for operating and then finish and go come back. No, still I give him the idea, but I don't if we can succeed to do it or not. But I will again and again, talk it with him with that. It's to have some neurosurgeon from high income country to go to the LMIC for more than 1 month or 2 months. This is more interesting than go for 1 week and come back home. I think there is another.
Yes, please go ahead.
Alexander?
Yes, hello.
Yes.
Hello, everybody. Professor Abadi, thank you very much for your program talk. Actually, I believe that all your efforts will be incorporated and will be materialized. And this, I want to say that I've been affiliating with the WFNS for more than 15 years already, and I know personally and recent and the next presidents, and many people from the administrative committee, and so on, so on. And believe me, I worry very much about the situation in WFNS. And as a person who voted for you, I supported you at this voting. I want to ask you as a president, because you're a president, you're a person who guarantees in the superiority of bylaw and constitution of WFNS based on the absolutely democratic principle. And I ask you to provide this realization of democratic principles in solution of this difficult situation of in the WFNS. And I ask you to make a step towards the how to say, maybe another side. So I don't know how to say it. So, and I believe that wiseness will win in this situation, and I will believe, and the WFNS will be a real leader and real coordinator for all the neurosurgeons of the world. So thank you very much. And
okay, I have maybe I have to answer you first, because you are right. This is one of the amendments which passed on 2022. It's, for example, the Committee of Constitution and Bylaws. Now it's the chair of this committee, even if this committee is a standing committee. The standing committee, it means that the chair is elected, okay? So
yeah.
Even if he elected, the chairman of the Constitution and Bylaws is named by the president. And this is very important, because before, for example, what you are request, you can just to me directly, and I put it. I send it to the CNB, and they should to answer me in the as soon as possible, and put it in the among the amendment that we will of course present in the next World Congress, I hope in Madrid 2025. So if you have any request that I just heard from you, just send it to me, and we can discuss it, and we will change it if
of course,
if they need change, of course.
I just know. Well, thank you very much, but I just only ask you to respect the principles of democracy inside of the government. And that's all. Thank you. And I believe that everything will be.
Don't worry. I am working very, very hard. This is why I told to Anila we will change. There is the truth and the reality. There is some problems when I arrive in as the president. It's not easy. This is why the guys sometimes put something without my approval, and I think this is we will have. I already sent email asking for the executive committee, and it will be I hope in April, and to discuss all this point, because it's very important. That you are right. We are elected, we are represent the body of the WFNS, which is the executive committee. So the president here to follow this constitution and bylaws. If no, there is no democracy, no transparency, and it's not good.
Yeah, thank you, and I believe that it's really. Everything will be settled up in the WFS. And thank you. Thank you.
Thank you, 𝑁𝑎𝑗𝑖𝑎. So wonderful talk. Just I want to encourage you. So maybe the WFNS itself is one is education, of course. Second one is of course WFNS Foundation. which the goal is donation, the instrument for low-income countries, I think. So now you are doing now. So I think you can push and work hard in the federation.
Yeah.
My all the best.
I start with my country. It's because it's I am more I have more chance to be close to some the foreign office ministry, for example. This is why I had this donation of $100,000. And this, I told him in the administrative council that each member had to push in their country and to do the same, at least for their country, because I know it's not easy for some country to have money for the Ministry of Health, and most of LMIC, the two poor ministry is the Ministry of Health and the Ministry of Education. And I hope that this point, the things will change in the future. But we can also, as you said, for example, you are the first donator to the WFNS, Yuko, and thank you very much for what you're doing for the WFNS, especially for young neurosurgeon, and how much money you have. I know before I was assistant secretary treasury, I saw how much. So thank you so much. And this is why I told you during my presentation that we need, even if it's a small, small like 1,000, each country send 1,000 by member, not by year, 2 year, etc. For example, we can have the revenue. We can have some revenue because actually, currently we have two important revenue. Only the World Congress and also the membership fees. Membership fees, there is many problem in this time, and people, we know that we are there is a international crisis, social and financial. So it's very hard for some countries to pay their membership fees. And also the same, we have a three World Congress successively with the difficulty to pay, their duty after in the end of the. So I hope with Madrid and what happened in Cape Town, the things will change. We hope, and we are working hard on this.
Okay, thank you very much.
Thank you.
Anyway, do your best. Thank you.
Thank you so much.
Thank you. So Sharon?
Anila, just to inform you, Prof. Binsu has just joined us. Good evening, Prof. Would you like?
Hi, Winshu.
Hi,
Sharon, how are you?
Hi, Professor Nadia.
Hi, you're working on Sunday.
I just finished my 10th operation.
I know now why you have the big number, the first number on the bypass in the world, because you are working even the Sunday. Okay, congratulations.
Yes. Thank you. I just come from Moscow, so yesterday I performed around 9 cases. Yeah, today is 10 cases. So I have to catch up my schedule. Yeah.
Okay, congratulations.
Thank you.
So I think we can go ahead, Anila.
Yes.
Please unmute your mic, Prof. Anila.
Sorry, if nobody has any questions for Dr. 𝑁𝑎𝑗𝑖𝑎, then I think we can go forward for the other presenters. Dr. 𝑁𝑎𝑗𝑖𝑎, thank you so much for joining us. And it was lovely seeing you and lovely hearing your talk.
Thank you. It's my duty and my big pleasure.
Thank you so much. Next, we invite Professor 𝑀𝑎𝑟𝑖 𝐾𝑢𝑠𝑢𝑚𝑖 to give her talk. She would be talking about how to operate large anterior skull-based meningiomas, saving important structures. Dr. 𝑀𝑎𝑟𝑖?
Okay, okay, I will start my presentation. Can you see my slide?
Yes, we can.
I'm very honored to do this presentation with WFNS president and also with Professor Yoko Kato. And I'm very thankful to Dr. Liu who prepared for this meeting. So I start my lectures. The title is How to Operate Large Anterior Skull-Based Meningiomas, Optimizing Vascular and Cranial Nerve Preservation. Surgical strategy. Skull-based meningiomas involved nerves and vessels, making surgery more challenging to the presence of blind spot across the nerve and vessels. So considering the use of microscope as primary approach, we are exploring the method to minimize blind spots and safely increase the extent of resection. Microscopic transcranial approach versus endoscopic transsphenoidal surgery is still controversial. For anterior skull-based tumors, for tumor located directly beneath the optic chiasm, it meaning midline type, endoscopic transsphenoidal surgery is being considered at first. For others, microscopic transcranial surgery is preferred. But for posterior fossa, microscopic transcranial approach is preferred. Craniotomy with endoscopic and scopic surgery is performed in conjunction with an exoscope or microscope as an adjunctive tools, but it is not performed as standalone procedures. For craniotomy, microscope or exoscope, I think microscope is nearly equal exoscope. I prefer the microscope. I use this Mitaka microscope. And also we have a exoscope made by Olympus. And also we have Olympus rigid endoscope. Exoscope is comparative with endoscope because it is small, so it can be used simultaneously with endoscope. During intracranial endoscopic surgery, it is essentially to have the skill to secure handle the endoscope and to be proficient in micromanipulation without any obstruction from the endoscope. So endoscopic assistant approach is preferred. This article is for tuberculum sera meningiomas. Endoscope is compensate for blind spot below the ipsilateral optic nerve of tuberculum sera. Today's representative cases. I show you 3 cases of anterior skull-based meningioma. It was operated by microscopic transcranial surgery with or without endoscope. First case is sphenoid-rich meningioma. Second one is a sphenoid orbital meningioma. The last case is the tuberculum sera meningioma. Innovation in surgery. Common strategy includes nerve monitoring, skull-based drilling at attachment site for hemostasis, and avoiding coagulation around blood vessels to preserve arachnoid tissue when blood vessels are involved, and using endoscope in blind spots. For anterior skull-based tumors, front lateral approach is selected. with lateral extension from the side to preserve olfactory function. But if tumor is a very huge one in midline, I do not avoid anterior basal interhemispheric approach. Optic nerve decompression and resection of the anterior crinoid process are performed, ensuring confirmation of normal anatomy at skull base. First case is phenol-rich meningioma. This 58-year female phenol-rich meningioma, she have only headache, but tumor vessels including in this tumor, and this internal carotid artery fed to the tumor. But fortunately, her the sphenoparietal sinus is almost occluded. So we sacrificed this vein. And also we do not embolization preoperatively. Now I cut meningoorbital band and elevate dura propria from superior orbital fissure and drilling optic canal first, and I do decompress of optic nerve first. Then I confirm where is the anterior crinoid process, and I take out the anterior crinoid safely. And I coagulate dura first and detachment, devascularize of the tumor. Then I open the dura and distal transluvian approach is studied. It makes operation field much more wider. Then I make a tumor smaller. This tumor is a little bit hard one, so I take a tumor piece by piece. Now I found olfactory nerve here, and take a tumor, keep arachnoid, and make tumor smaller. Then I coagulate feeding artery from the skull base and find the optic nerve. So I confirm where is the optic canal, and I cut the pulsar ligament and open the optic canal dura. So finally, I coagulate the feeding artery inside of the optic canal and take out the tumor inside of the optic canal. Now I'm keeping arachnoid and taking a tumor from the tentorial portion. So now making a tumor smaller, and here is a middle cerebral artery and internal carotid artery. I didn't coagulate tumor near the vessel to keep arachnoid and take out the tumor from the vessels. Then almost tumor is gone. This is the final portion. Attachment is here, so tumor is, I make tumor gather to the attachment and take the tumor out. But still I make a tumor smaller. This is the last portion of the tumor, and I found oculomotor nerve here to take out all of the tumor. So I performed, I think, some grade 2 tumor removal. This patient have a small aneurysm here, so I clicked later and make hemostasis and finish this approach. So MRI shows no diffusion high spot and all tumor is gone. Let's move to the sphenoorbital meningiomas. Sorry, it's the left side. Patient have a left sardinal palsy, and this is angiogram shows MMA feeds these tumors, and also middle cerebral arteries feeding these tumors. We have no embolization for this patient. A sphenoorbital meningioma usually invade to the bone, and easy recurrence. So we drill out the sphenoid and orbital wall first, and then I take the tumor in the extradural portion. It's a little bit invade to the cavernous sinus. And I take out the bone and open the optic canal and take out the anterior clinoid. Then I open the dura and devascularize and detachment tumor from the dura, and now I'm separate tumors from the middle cerebral arteries. Some part this tumor have keep arachnoid, but some part tumor invade directly to the middle cerebral arteries. So first I try to dissect this tumor sharply, but here is a M2 segment. It's very tight at the heat. So I use ultrasound aspirator. It's called sonopet, and make tumor smaller, but this very hard tumor. It's difficult. So fortunately, I find this membrane. This membrane is maybe tumor membrane or some reaction membrane. But this membrane protects the middle cerebral arteries in this patient. So I keep this membrane to take tumors. Some part I take tumors sharp dissection, but almost part I take tumors with some kind of the blunt procedures. So now I'm taking a tumor, a skull-based portion, and find oculomotor nerves. It's covered by arachnoid. I take almost tumor out, so I take out the dura of the attachment. And finally, I do a hemostasis. This is the final view. A small diffusion high intensity spot is found, but all tumor is gone and the patient has no symptom. And also middle cerebral arteries are protected. But this tumor is WHO grade 2 meningioma, so we do a radiation therapy after surgery. Next, tuberculosis meningioma. True tuberculosis meningioma is not equal to the planned meningiomas. True tuberculosis meningioma grow posteriorly and superiorly, so displacing the optic nerve superiorly and laterally. So it's very difficult to take out because for blind spot. Transcranial approach versus endoscopic and nasal approach is still controversial for small to medium size meningiomas. Some article shows endoscopic and nasal approach is better than transcranial approach for visual outcome and resection rate. But other article says resection rate, transcranial approach is preferred than endoscopic approach. It's still controversial. But endoscopic approach are a little bit better than transcranial approach. Is maybe everybody thinks so. But disadvantage is CSF leak and lateral extension, and also handle of arterial injuries. So this time I choose transcranial approach. So this article is about transcranial approach. This is European skull-based society's recommendation. European and some places for transcranial approaches recommend for front temporal craniotomy with early extradural optic canal decompression. But some case I'm not agree with bilateral approach is very risk. Some huge tumors, it's with little bit sweet for bilateral approach. And also, endoscopic assistant from the temporal craniotomy is very beneficial to compensated for blind spot. Our case, 70 years male patient, light visual disorder and headache. This tumor size is a bigger, most large portion is 4 centimeters. On the right ICA and ACA is somewhat within the tumors. And also this tumor progression in the right optic canal. So we choose open craniotomy because vascular involvement. And this patient decreased the vision in right eye with progression of the tumor into the right optic canal. And also the tumor is skewed to the right side. So right front temporal craniotomy and lens approach was chosen. The right optic nerve below become a blind spot. So using endoscopy concurrently is beneficial. So this is a craniotomy, and here is maybe a blind spot. So endoscopy is beneficial. So firstly, it's the same. We take out of the canal, bone, and anteroclinoid. And I cut falcium ligament and confirm where is optic nerve. And to some surgeons do not do the distal translumion approach, but I prefer to do this because of the operation field wider. Now I'm coagulating tumor attachment site and take out the tumor, keep arachnoid. This tumor is getting bigger under the right frontal lobe, under the frontal lobe. So I'm taking the tumor piece by piece to keep arachnoid to find the ACA. I also use sonopet and scissors to make tumor smaller and do not coagulate tumor near vessels. Here is a frontal lobe. This is ACA. This tumor is under the frontal lobe side tumor. I take tumor, put to the attachment site, and keep arachnoid, take a tumor out. Then only under the optic nerve, a tumor under the optic nerve is remain. So I'm coagulate attachment site and make tumor smaller. This time I cannot show you the endoscopic procedure, but I use this and take tumor residual part under the optic nerve, and I take out all of the tumor, and Simpson grade 2 removal is achieved with patient. Patient vision is getting better. Only small diffusion high intensity spot is shown, but tumor is gone and patient is no symptom, and visual activity is getting better. This is my take-home message. In meningioma, preserving membrane is crucial. Also, bleeding control can often be achieved through endovascular embolization or skull-based technique, but this time I do not choose endovascular embolization. Complications are most likely to occur in case where the tumor is firm and strongly adhered to the vital structures. So find some membrane is crucial. Considering normal anatomy, utilize the appropriate approach. Use endoscopy as needed. Thank you for your attention. I finish my presentation.
Thank you so much for the wonderful presentation. Just a quick question from my side. For the last case that you showed for the tuberculum cell meningioma, you chose the pterional approach. Would you ever consider like a bicoronal approach, or you think that in your hands the pterional approach is actually the best?
So, good question. Thank you for your question. Yeah, we are thinking about basal interhemispheric approach as well. But this case is a tumor is skewed to the right side and invaded only right optic canal. So to open optic canal, the lateral approach is much easier to open optic canal. So we choose the lateral approach. But under tumor under the optic nerve, it will be the blind spot. So we have to take care of it.
Okay. Thank you so much. Anybody has any questions for Professor Kusumi?
Maybe you can ask a commentator, please. Alexander?
Yeah. Can I? Okay, thank you. Thank you, Professor Kusumi. Thank you very much for excellent presentation. Thank you for excellent videos. I recognized the Fukushima style surgery and really enjoyed it. Thank you. Thank you very much. According, you titled your presentation the preservation of vascular and neural structures during skull-base surgery. And actually, you showed it really in, by applying the micro technique. That's true, I agree. But I'd like to remind that the intraoperative neuromonitoring is very helpful. And we should rely on it more and more. And I believe that you also work with the neuromonitoring team. And my question will be, how much do you rely on the data of intraoperative monitoring, and in cases you presented, what nerves do you monitor during the surgery? Next question.
Thank you for your question. Yeah, it depends on monitoring, but if VEP, visual evoked potential, it's a very sensitive. So if visual evoked potential is getting lower, we stop or change our approach. Sometimes, VEP is never recovered as usual.
Okay, thank you. And when you have a drop of signal from the third nerve, do you?
Yeah, third nerve.
Because I usually stop my manipulation when I have a 50% drop of signal. I stop manipulation and leave the piece on the nerve usually. Maybe wait a bit, some minutes for restoration. If it doesn't restore, we stop. This is from our practice. And also the discussion, I can maybe some more critical points. So excuse me, but I have a right for this. According to the second humor you presented, for me, I'd classify it more as the medial sphenoid wing meningioma than sphenoorbital. It's like maybe I didn't see all the MRIs, but the MRIs, the pictures you presented, I think mostly depict the medial sphenoid wing, medial and yes, medial sphenoid wing. And another critical remark about the third case, you presented as tuberculum cell meningioma. It's quite a big tumor. It's maybe initially was a planus sphenoidale, but then it extended to the sphenoid. But I'm not sure about this. But in my practice, in cases like this, I use the regular frontolateral supraorbital approach, intradural. I think it's more safe. And also, what I use in my practice also, I always use the site of craniotomy at the site of better vision. less compressed nerve. I have a publication in Neurosurgical Review. It's very well illustrated why I do this on the model. You can find it in this article, and I illustrated it very well while I use it. From my point of view, the use of bilateral or interhemispheric approach for tuberculum cell is absolutely unwise. Too traumatic. It's even too dangerous for the patient. Unilateral. From other side, to actually you avoided the fraction of the frontal lobe. Maybe this is the reason your approach was also less traumatic, maybe more complex, but less traumatic. So I agree. So I didn't criticize, I just express my option. So, and finally, thank you very much for really good
Thank
set.
you very much for your comments. Yeah, very good.
Thank
Good.
you. Thank you. Thank you.
Oh,
Yeah,
Crazy.
I have a question and a comment for our colleague Mari.
yeah. Thank you. Thank you. I'm very honored to be with you.
The first question: in how many cases you shown us 3 cases where you achieved the total resection, but in your experience and your study, how many cases you are obliged to let a small residue because you have some problem to to dissect first the first case. For example, the tumor was really very inner to the carotid artery. And also I am agree with our colleague about the meningioma of tuberculosis. We know that is discovered during the operation, because there is no in the MRI landmarks to tell you that it really is from meningioma from tuberculoma or from the above. So this is my commenter. But how percentage you have the complete resection?
Yeah, thank you for your difficult questions. It depends on tumors. If tumors separate, I can separate tumor from the vessels or nerves. As usual, I take everything. But if tumor is tight adhesion to the large vessel, or especially for perforator, it's difficult to separate perforator as usual. So sometimes I left tumor backside of the perforator's vessels, but not so much percentage. Usual, if tumors and between arachnoid between tumors and vessels is still alive, maybe we can take out all of the tumors to separate from the perforators. So it depends on tumors.
Thank you.
Thank you.
Yeah. Unmute, please.
Okay, yeah.
Abhidasha, any question for her or encouragement for her, please?
Dr. Kusumi, very good cases and very nice technique. I just wanted to ask for the first 2 cases, when you unroofed the optic canal, there was tumor there or not much?
So,
Okay.
Tumor.
In the optic canal, you decompressed the optic nerve. You unroofed the optic canal. Did you find any tumor there?
Yes. all of the case, I find some tumors inside of the optic canal. And
Okay.
if no tumors inside optic canal, decompression first is much better for the optic functions after surgery. So previous articles also recommend you to decompression optic canal first to remove the tumors.
Okay. Thank you.
So, Kusumi-sensei, thank you very much for your nice presentation. And Dr. Alexander from Ukraine, he's one of the best skull-based neurosurgeon. And sometimes you can learn from him.
Yeah.
And also, of course, the Abida Shah. And also maybe the Naja, please remember her name. She is a female neurosurgeon, but one of the best female skull-based neurosurgeon.
Of course, I
Please
know.
take. So please take her your maybe some committee in future, please.
Yeah, of course.
Thank you so much. Okay, wonderful. The
And I'm
conversation.
especially on this. My specialty is skull base, so I will remember. Okay.
Okay, thanks. Thanks a lot. Anita?
Yeah. So I think if all the questions are done, we can go to our next speaker. Our next speaker is Dr. 𝑀𝑎𝑟𝑖 𝐾𝑢𝑠𝑢, and she will be talking about her experience for bypass surgeries.
Hi, hello everybody. Am I audible?
Yes.
Yeah, こんばんは、先生. Hello everybody, and thanks for interesting presentations, Professor 𝑁𝑎𝑗𝑖𝑎 and Professor 𝑀𝑎𝑟𝑖 𝐾𝑢𝑠𝑢𝑚𝑖. And before my presentation, I wanted to thank my great pleasure to Professor Yokokata Sensei for giving me this opportunity, and it's a great honor for me to speak here. And today, my presentation's topic is it seen or?
Yes, we can see it.
Okay, my presentation's topic is our experience of bypass surgery with cases. In this table, I want to show our whole bypass surgery during 3 years. We did 23 bypass surgery, and among these patients, 7 of them we did endovascular embolization, and unfortunately, 1 patient's bypass didn't work, and 2 patients had wound problem after surgery. And I have to mention that our 2 patients died after surgery. And the first first patient is a 61-year-old male. He had headache, numbness, and a left-sided hemiparesis. And in this angiogram showed according to this angiogram, CT angiogram, we put right ICL occlusion on cervical segment diagnosis, and we did right STA for bypass surgery, and this is post-operation angiography. Here on the right side, and the second case is the second patient is 65 years old female with headache, numbness, vision defect, and for this patient we choose 2-step surgery, combined treatment. First step was bypass surgery, and then the vascular embolization. Her diagnosis was saccular aneurysm. Actually, she had aneurysm of ICL on both sides, and the right side, as we can see, the on the supracranial segment, there is a saccular aneurysm, and we did left-sided high-flow bypass, extracranial artery, and radial arterial graft, and M2 bypass surgery. And in this angiogram, the post-operation angiogram, and this is second step of endovascular embolization here, and first endovascular embolization. And the third case, third patient is 45 years old male. with total ophthalmoplegia of the right eye. This is actually an interesting case. He had the right ICA aneurysm on cavernous segment, and we did right-sided STA, CA bypass, bypass. The first step was, and this is TSA, and here's video, some with STA, and for donor and recipient artery we dissected, and with fish mouth bypass technique we did in here anastomosis, and usually our anastomosis takes 30 minutes. 30 minutes, and first we put 4 stay suture, 2 and 4 stay suture, and we did our bypass. As you can see, and the second step is endovascular parent arterial occlusion after 6 days of bypass surgery. And the result is before operation right eye total ophthalmoplegia, and 6 days after parent arterial occlusion, and after 1 month, and after 2 months, he can move her, he can open her eye, as you can see. And this case is a 46-year-old male with stenosis of MCA. Here Vizaro is shown, and he had ischemic stroke 3 times, and we did STA M4 bypass here also. With transfusion approach, we dissected the M4. M4 artery, and this is the recipient artery, and the donor artery we STA frontal branch, and we prepared, and with fish mouth technique we did anastomosis here. We checked the patency of the anastomosis, and with Doppler also here. Oh, yeah, I'm sorry. And the next case is this male, 50 years old. He had cerebral symptoms, not specific neurological deficiency, but he had cerebral symptoms of photophobia. And in this patient also, we did a second step surgery, bypass and endovascular embolization. And he had the giant aneurysm of left MCA here, and we did left STA MCA bypass for this patient also. With paternal craniotomy transfusion approach, we prepared our donor and recipient artery. Our recipient artery is M4, and donor artery is STA. And during bypass surgery, we have to keep our field clear, and don't use the more water, as I used to but this is my this operation did by my supervisor. And the second step was the endovascular embolization here and this side after bypass sides. This this patient is came our hospital with dizziness and fatigue, and this is emergency case that during GSA perforation of the right ICA noted, a microballoon was installed at the level of the perforation, and the vessel was occluded with microspirals, and we took this patient for the bypass surgery, and her diagnosis was right ICA stenosis, brachycephalic artery stenosis, and we did after occluded ICA, we did bypass surgery on the right side, STA, MCA, and this is last case with myomelia disease. We did bypass the right side, and after 3 or 6 months, we will check the with, and we will do on the left side. And this is STA, superficial temporal artery, and we dissected it, and we are opening field for MCA and for the section here. This is tunnel artery, STA. After clipping the MCA M4, we put anastomosis. Again, fish mouse technique. Thank you for attention, and in here I put the link our YouTube channel. We put these videos from our bypass surgeries. Thank you.
Thank you very much, Dr. 𝑗𝑖𝑎 𝐸𝑙. It was a fantastic presentation.
Thank
I
you.
would invite Dr. Shubin for any comments, Dr. Yoko Kato for any comments.
Maybe the Mohira, like she learned a lot from the Shubin place. Maybe Dr. Shubin?
Hi, Dr. Mohira. Nice to see you again.
Hello, Professor Shubin. Hi.
You mentioned that you have 2 cases died for what?
Yeah.
What's the problem?
They had other clinics, but actually I didn't attend for this patient because from last year I'm in this operation. So, but I know that only one cases the patient's bypass didn't work, and yeah.
Didn't work. You mean what? You mean it's not patent? It's thrombosed?
Yeah. Yes. No, not thrombosis, but yeah, with thrombosis, I think. Yeah, with thrombosis.
Okay. So how many cases you attended for this kind of bypass?
Bypass surgeries? Yeah, 5 or 6, I think.
Okay.
5 or 6, yeah. 2 high flow bypasses and ST bypass. Yeah.
Okay, great.
And the patients died from ruptured aneurysm. Yeah. And 2 patients died from ruptured aneurysm.
Okay.
So Shubin, maybe today that we have so many YNS is listening, so maybe you can give them some point, the important point of the bypass surgery.
So yeah, I think maybe yes, anastomose never touch the intima. It's very critical. So I noticed that your technique still have some touch about the intima, and that may be the cause of the thrombus.
Yeah. Yeah. Okay, I understood.
Thank you.
Thank you for your comment. Thank you. Yeah.
Yeah. Are there any other questions for all our 3 participants? Please raise your hand up if anybody has any questions for Dr. Ejia, for Dr. Kusumi, and for Dr. Jalilova.
Maybe Alexander.
Yes, I'm ready because I'm from the telephone. Thank you very much for good presentation. Thank you for showing really excellent technique of micro anastomosis. I think you taught in Japan. It's absolutely Japanese style. You show anastomosis. And what I'd like to ask you, do you use the indirect anastomosis, especially in patients with moya disease, or stop at the just direct microanastomosis? Because it has been shown, especially also by Japanese authors, that such a hybrid anastomosis, direct and indirect, works much better, and in the remote observation shows a much better results than only one or two direct anastomosis. In your practice, did you perform this kind of hybrid anastomosis? And from the other hand, in children, where it's very difficult to stitch very small anastomosis, sometimes it could be enough to create indirect anastomosis. Have you done it in your practice?
Yeah, we for all cases, the last case with one myeloma disease also we did combined anastomosis and combined bypass, and with stenosis we did direct anastomosis. Yeah, direct bypass.
Okay. Thank you. My congratulations.
Thank you. And I have to mention I had completed my fellowship neurosurgery under Professor Ryoka Sensei, and there I learned my bypass techniques, and I trained a lot in there. And Professor Kato always checked me and gave me some advices. And thank you.
Yes.
Thank you for your.
Thank you, and good luck. Thank you.
Yeah,
Thank you.
congratulations, Mohira. It was wonderful talk. Thank you very much.
Thank
And
you.
also your anastomosis plane was very beautiful.
Right. Thank you.
It's excellent, I think. Thanks
Thank
so
you.
much.
Thank you very much.
Arigato.
Hi, Mohira.
Kevin?
Thank you, Mohira.
Hi, Professor Ravi Pasha.
Nice presentation.
Thank you very much. Thank you. Bye.
Okay.
Well done, Mohira.
Professor Sharon, thank you very much. Thank you.
You join us very often.
Yeah, okay. I will try. I will do my best.
Keep it up.
Okay. Yeah. You can continue, please. Yes.
Okay. Thank you very much.
So maybe Evelyn. So she's from Peru now. She is with us now. Dr. Evelyn?
What?
Dr. Evelyn, who is attending the webinar. She's from Peru. So you want to say something, Evelyn? Because Mohira used to be with us. So Evelyn is doing every night this 1 or 2 bypass practice. Okay, thank you very much. So, Anila?
So I think, shall we just wrap it up, our webinar from today then?
I think so.
Yeah, Dr. Yako-Koto, you want to give, or Sharon, you want to say some parting remarks?
Yes,
Right.
the first Sharon, please.
Yeah, I just want to say thank you everyone for joining us today. We really appreciate it, especially Prof. Wozniak and Prof. Binsu. You are supporting the women in this community. Thank you very much. And we appreciate all the suggestions and advices you give us. Much appreciated.
Yeah, better Sharon. She is now in the United States. Which city? It's
No,
3 a.m., she said. Are you attending some conference?
Yes, Society of Brain Mapping and Therapeutics.
Oh, okay. So 3 a.m. in US. So you want to say something?
No, it is a good webinar. Very nice demonstrations and very good message by Professor 𝑁𝑎𝑗𝑖𝑎. And I think we can now go ahead. Anila.
Thank you so much, Dr. Yako-Koto, for your last remarks, please.
Okay. So before me, maybe the Dr. 𝑁𝑎𝑗𝑖𝑎, you want to say something as a president?
Oh, it's a very, very nice and wonderful webinar. I appreciate all the presentation, especially the presentation on skull base and from me, from Marie, and also our young neurosurgeon. And really, it's very, very nice. Thank you.
Okay.
Thank you
very much.
Thank you.
So 𝑁𝑎𝑗𝑖𝑎, thank you very much. For maybe in a few months, maybe you will have some foundation meeting. So maybe you can get more donation from all over the world. So you can provide some equipment to the low-income countries, please. Thank you very much. Thank you very much for the webinar today.
Do our best.
So we learned a lot from all of you. Thank you very much.
Thank you
so
very
much.
Thank you.
Thank you.
Okay, so see you next time.